Janus kinase JAK inhibitors are a class of medications used in rheumatology to manage autoimmune and inflammatory conditions by interfering with the JAK-STAT signaling pathway, which plays a crucial role in immune cell activation and inflammatory processes. Here's a breakdown. Types and names of JAK inhibitors. 1. Tofacitinib, Xeljanz. Type, JK1 JK3 inhibitor. Uses, rheumatoid arthritis Ray, psoriatic arthritis Say, ulcerative colitis. Dosing, oral, 5 milligrams twice daily or 11 milligrams extended release once daily. 2. Baricitinib, Olumiant. Type, JAK1 JAK2 inhibitor. Uses, rheumatoid arthritis RA, severe COVID-19, off-label. Dosing, oral, 2 milligrams once daily. 3. Upadacitinib, type JAK1 inhibitor. Uses, rheumatoid arthritis, psoriatic arthritis, SA, ankylosing spondylitis, atopic dermatitis. Oral, 15 milligrams once daily. 4. Filgotinib, Jyseleca, type selective JAK1 inhibitor. Uses, rheumatoid arthritis, RA, ulcerative colitis, UC. Dosing, oral, 200 milligrams once daily. 5. Paficitinib, type pan-JAK inhibitor, targets JAK1, JAK2, JAK3, and TYK2. Uses, approved in some regions for rheumatoid arthritis. Dosing, oral, varies by region and indication. 6. Deucravacitinib, SOC2, type selective TYK2 inhibitor, part of the JAK family. Uses, psoriasis. Dosing, oral, 6 milligrams once daily. Clinical uses in rheumatology. 1. Rheumatoid arthritis, RA, most commonly treated with JAK inhibitors, particularly for patients who have not responded adequately to conventional DMARDs, disease-modifying anti-rheumatic drugs, or TNF inhibitors. 2. Psoriatic arthritis, A. JAK inhibitors are increasingly used as an option for patients with PsA, offering an oral alternative to biologics. 3. Ankylosing spondylitis. Newer JAK inhibitors like upadacitinib are now being approved for AS, particularly for those who do not respond to NSAIDs or TNF inhibitors. 4. Ulcerative colitis, UC. Tofacitinib and filgotinib have been used for treating moderate to severe UC when conventional treatments are insufficient. 5. Atopic dermatitis and psoriasis. These inflammatory skin conditions are also being managed with JAK inhibitors, broadening their therapeutic use beyond classic rheumatologic diseases. Precautions and safety concerns. 1. Infection risk. Increased risk of serious infections, including tuberculosis, TB, opportunistic infections, and herpes zoster, shingles. Patients should be screened for latent TB before starting therapy. 2. Thromboembolism. Higher doses of JAK inhibitors, especially tofacitinib, have been associated with an increased risk of deep vein thrombosis, DVT, and pulmonary embolism, PE. Caution is advised in patients with a history of thromboembolism. 3. Malignancy. Long-term use of JAK inhibitors may be associated with an increased risk of malignancies, including lymphoma and skin cancers. 4. Hematologic abnormalities. JAK inhibitors can cause decreases in blood cell counts, e.g. neutropenia, lymphopenia, necessitating regular blood monitoring. 5. Lipid elevations. These medications can cause elevations in cholesterol levels, necessitating monitoring of lipid profiles and potentially adjusting cardiovascular risk management. 6. Liver function. Periodic monitoring of liver enzymes is recommended, as JAK inhibitors can cause elevations in liver function tests, LFTs. 7. Pregnancy and lactation. The safety of JAK inhibitors during pregnancy and lactation has not been well established. They are generally not recommended for use during pregnancy. Summary. JAK inhibitors represent an important class of targeted therapies in rheumatology, offering an oral treatment option for various autoimmune diseases. However, they require careful patient selection and monitoring due to potential risks, including infections, thrombosis, and malignancy. The use of JAK inhibitors in patients over 65 years old requires special consideration due to increased risks associated with aging and comorbidities. Here's a detailed look at the implications. Considerations for JAK inhibitor use in older adults. 1. Increased infection risk. Elderly patients, particularly those over 65, have a higher baseline risk of infections due to immune system changes with aging. JAK inhibitors can further increase this risk, particularly for serious infections such as pneumonia, tuberculosis, TB, and opportunistic infections. Clinical advice. Careful screening for latent infections and close monitoring for signs of active infection are crucial. Vaccinations, e.g., for pneumonia, influenza, and shingles, should be updated prior to starting treatment. 2. Cardiovascular and thromboembolic risk. Older adults are more prone to cardiovascular issues, and JAK inhibitors, especially at higher doses, have been associated with an increased risk of venous thromboembolism, VTE, deep vein thrombosis, DVT, and pulmonary embolism, PE. The FDA has issued warnings about the use of tofacitinib in patients over 50 who have cardiovascular risk factors. Clinical advice: evaluate cardiovascular risk factors thoroughly before initiating treatment. Lower doses and alternatives should be considered in patients with a history of thrombosis or cardiovascular disease. 3. Malignancy risk. Aging is a known risk factor for cancer, and long-term use of JAK inhibitors may further increase the risk of malignancies such as lymphoma and skin cancer in elderly patients. Clinical advice: regular screening for malignancies and skin checks are recommended. Weigh the benefits of treatment against the increased malignancy risk in older patients. 4. Hematologic abnormalities. Older patients may be more susceptible to hematologic side effects such as anemia, neutropenia, and thrombocytopenia when using JAK inhibitors. Clinical advice: frequent monitoring of complete blood counts, CBC, is important in older adults to detect early signs of bone marrow suppression. 5. Liver and kidney function. With aging, there can be a decline in liver and kidney function, which may affect drug metabolism and excretion. JAK inhibitors can elevate liver enzymes and may require dose adjustments in patients with hepatic or renal impairment. Clinical advice: baseline liver and kidney function tests should be done, with ongoing monitoring. Dose adjustments may be necessary in cases of significant impairment. 6. Polypharmacy considerations. Elderly patients are often on multiple medications for comorbid conditions, increasing the risk of drug interactions. JAK inhibitors can interact with drugs metabolized by the CYP450 system. Clinical advice: review the patient's medication list for potential interactions, particularly with immunosuppressants, anticoagulants, and medications that affect liver metabolism. 7. Fragility and functional decline. The elderly are more susceptible to frailty and functional decline, which can be exacerbated by the side effects of JAK inhibitors, such as muscle weakness or fatigue. Clinical advice: consider the patient's overall functional status and quality of life when deciding on treatment. Alternative therapies or dose reductions may be more appropriate in frail patients. Summary: JAK inhibitors can be used in patients over 65, but with caution due to the increased risks of infections, cardiovascular events, malignancy, and hematologic abnormalities. Comprehensive patient evaluation and close monitoring are essential, and dose adjustments or alternative treatments may be necessary depending on the patient's comorbidities and functional status. In rheumatoid arthritis, RA, JAK inhibitors have become an important treatment option, particularly for patients who have had an inadequate response to conventional synthetic DMARDs, e.g., methotrexate, or biologics, e.g., TNF inhibitors. Here's a detailed exploration of their use in RA. Hack role of JAK inhibitors in rheumatoid arthritis treatment. 1. Mechanism of action. JAK inhibitors target the Janus kinase, JAK family of enzymes, JAK1, JAK2, JK3, and TYK2, which are involved in the intracellular signaling pathways of cytokines and growth factors that drive the inflammatory processes in RA. By inhibiting these pathways, JAK inhibitors reduce the production of pro-inflammatory cytokines, e.g. IL-6, IFN-Guang, that contribute to synovitis and joint destruction. 2. When are JAK inhibitors used? Moderate to severe RA. JAK inhibitors are typically used in patients with moderate to severe RA who have not responded adequately to methotrexate or other DMARDs, or who are intolerant to these treatments. Monotherapy or combination therapy. JAK inhibitors can be used as monotherapy or in combination with methotrexate. They are particularly useful in patients who prefer oral therapy or have difficulty with injections, which are required for biologic therapies. TNF inhibitor non-responders. For patients who do not respond to TNF inhibitors, e.g. etanercept, adalimumab, JAK inhibitors offer an alternative mechanism of action. 3. Approved JAK inhibitors for RA, tofacitinib, Xeljanz. Approved for moderate to severe RA in patients who have had an inadequate response to methotrexate. It is available in oral form and as an extended release formulation. Baricitinib, Olumiant, approved for moderate to severe RA, typically in patients who have not responded to one or more TNF inhibitors. Upadacitinib, Rinvoq, a selective JAK1 inhibitor, approved for moderate to severe RA. It is used in patients who are intolerant to or have had an inadequate response to methotrexate. Efficacy in RA, rapid onset of action. JAK inhibitors tend to have a relatively rapid onset of action compared to conventional DMARDs. Improvements in symptoms can often be seen within 2 to 4 weeks. Clinical trials. Clinical trials have demonstrated that JAK inhibitors are effective in reducing RA symptoms, improving physical function, and inhibiting structural damage. They have shown similar or even superior efficacy compared to TNF inhibitors in some studies. Treatment targets. JAK inhibitors help patients achieve low disease activity or remission, which are key treatment goals in RA management. Safety profile in RA. Infection risk. The most common serious side effect of JAK inhibitors is an increased risk of infections, including pneumonia, TB, and herpes zoster, shingles. Regular screening and preventive measures, e.g. vaccinations, are necessary. 2. Thromboembolism. There is an increased risk of deep vein thrombosis, DVT, and pulmonary embolism, PE, particularly at higher doses. This risk may be more pronounced in patients with cardiovascular risk factors, which requires careful assessment before starting therapy. 3. Malignancy. An increased risk of malignancies, such as lymphomas and skin cancers, has been observed in long-term use, although this risk needs to be weighed against the benefits of controlling RA inflammation. 4. Lipid elevations. JAK inhibitors can cause increases in lipid levels, including cholesterol. This necessitates monitoring and management of cardiovascular risk factors. 5. Hematologic abnormalities. Monitoring for neutropenia, lymphopenia, and anemia is recommended due to the potential for bone marrow suppression. 6. Liver function. Liver enzyme elevations can occur, requiring regular liver function tests, especially in patients with pre-existing liver conditions. Special considerations in RA treatment. 1. Patient selection. JAK inhibitors should be used cautiously in patients with a history of chronic infections, recurrent herpes zoster, or a history of venous thromboembolism, VTE. They are also not recommended during pregnancy or breastfeeding. 2. Age considerations. In older adults, particularly those over 65 years of age, the risks of infections, cardiovascular events, and malignancies are higher. The benefits of treatment should be carefully weighed against these risks. 3. Drug interactions. Caution is advised when JAK inhibitors are used alongside other immunosuppressants, e.g. azathioprine, or medications metabolized by the liver, as there can be significant drug interactions. 4. Monitoring. Regular monitoring of blood counts, liver enzymes, lipid profiles, and screening for infections is critical for managing the risks associated with JAK inhibitors. Conclusion. JAK inhibitors represent a potent therapeutic option in the management of moderate to severe rheumatoid arthritis, particularly for patients who do not respond adequately to conventional DMARDs or biologics. They offer the convenience of oral administration and can be effective as monotherapy or in combination with methotrexate. However, their use requires careful patient selection and regular monitoring due to the risks of infections, cardiovascular events, and other potential side effects. Janus kinase JAK inhibitors have emerged as a promising treatment option for axial spondyloarthritis, axial SPA, including both ankylosing spondylitis, AS, and non-radiographic axial SPA, NRAX-SPA. These conditions are chronic inflammatory disorders primarily affecting the spine and sacroiliac joints, and JAK inhibitors provide a new therapeutic avenue beyond traditional biologic agents like TNF inhibitors. Here's a detailed look at their use in axial SPA. Background of axial SPA treatment. 1. Traditional treatments, nonsteroidal anti-inflammatory drugs, NSAIDs, are typically the first-line treatment for axial SPA. If NSAIDs are insufficient, biologic DMARDs, particularly TNF inhibitors, e.g. adalimumab, etanercept, have been the standard for managing moderate to severe disease. IL-17 inhibitors, e.g. secukinumab, ixekizumab, are also used, especially in patients with inadequate response to TNF inhibitors. 2. Unmet needs. Not all patients respond adequately to TNF or IL-17 inhibitors, leading to the need for alternative therapies. Some patients prefer oral medication over injections or infusions, making JAK inhibitors an attractive option. JAK inhibitors in axial SPA. 1. Mechanism of action. JAK inhibitors block the signaling of multiple cytokines involved in the inflammatory process of axial SPA, including IL-6, IFN-GAI, and IL-23, by inhibiting the JAK-STAT pathway. This broad cytokine inhibition helps reduce inflammation in the spine and sacroiliac joints, which are central to axial SPA. 2 approved JAK inhibitors for axial SPA. Upadacitinib, Rinvoq. Upadacitinib has been approved for the treatment of ankylosing spondylitis in patients who have had an inadequate response to NSAIDs or biologic therapies. It is a selective JAK1 inhibitor that has shown promising results in clinical trials for AS. Tofacitinib, Xeljanz. Tofacitinib has also been studied in axial SPA, particularly in ankylosing spondylitis, and has shown efficacy in reducing disease activity. While not yet widely approved for axial SPA, it is used off-label in some cases. Baricitinib, Olumiant. Baricitinib has demonstrated effectiveness in axial SPA in clinical studies, though it is currently approved mainly for rheumatoid arthritis. Number 3. Efficacy in clinical trials. Upadacitinib. In clinical trials for ankylosing spondylitis, upadacitinib demonstrated significant improvements in ASAS-40, a measure of response in AS, compared to placebo. It has been shown to reduce pain, stiffness, and inflammation, and improve physical function. Tofacitinib. Clinical trials of tofacitinib in ankylosing spondylitis have shown significant reductions in disease activity and improvements in spinal mobility and patient-reported outcomes. Baricitinib. In early clinical studies, baricitinib showed efficacy in reducing inflammation and improving symptoms of axial SPA, though further studies are needed for broader approval in this condition. Clinical use in axial SPA. 1. When are JAK inhibitors used? Inadequate response to NSAIDs or biologics. JAK inhibitors are used in patients with axial SPA who have not responded adequately to NSAIDs or biologic therapies, TNF or IL-17 inhibitors. Monotherapy or combination therapy. JAK inhibitors can be used as monotherapy in axial SPA, providing an oral option for patients who may have difficulty with biologic injections or infusions. 2. Patient selection. AS versus NRX-PA. While most data for JAK inhibitors come from studies in ankylosing spondylitis, there is growing interest in their use for non-radiographic axial SPA, NRX-SPA. However, approval for NRX-SPA may vary by region and specific JAK inhibitor. Younger patients. JAK inhibitors may be particularly beneficial in younger patients with axial SPA who prefer oral therapy or who have concerns about long-term biologic use. Safety profile and considerations in axial SPA. 1. Infection risk. As with other indications, JAK inhibitors increase the risk of infections, including serious infections like TB, pneumonia, and herpes zoster. Patients should be screened for latent infections before starting therapy. Regular monitoring is essential, and patients should be advised to report any signs of infection promptly. 2. Thromboembolic risk. There is an increased risk of venous thromboembolism, VTE, including DVT and pulmonary embolism, especially at higher doses. Patients with cardiovascular risk factors should be assessed carefully before initiating therapy. 3. Malignancy risk. Long-term use of JAK inhibitors may increase the risk of malignancies, particularly lymphomas and skin cancers. Regular cancer screenings should be part of the management plan. 4. Lipid and liver function monitoring. JAK inhibitors can cause increases in cholesterol levels and liver enzymes. Baseline and periodic monitoring of lipid profiles and liver function tests are recommended. 5. Hematologic monitoring. Monitoring of blood counts is necessary, as JAK inhibitors can lead to neutropenia, lymphopenia, and anemia. Regular complete blood counts, CBC, should be performed to detect early signs of bone marrow suppression. 6. Age and comorbidities. Older patients, especially those over 65, may be at higher risk for complications such as infections and thromboembolism. Special consideration should be given to this population when prescribing JAK inhibitors. 7. Pregnancy and lactation. JAK inhibitors are generally not recommended during pregnancy or lactation due to potential risks to the fetus or infant. Women of childbearing potential should use effective contraception while on JAK inhibitors. Summary: JAK inhibitors offer a new and effective treatment option for patients with axial SBA, especially those who do not respond to NSAIDs or biologics. They provide the convenience of oral administration and have demonstrated efficacy in reducing disease activity, improving function, and controlling symptoms in both ankylosing spondylitis and potentially non-radiographic axial SPA. However, their use requires careful patient selection, regular monitoring for infections, cardiovascular risks, and malignancies, and ongoing evaluation of the balance between benefits and potential side effects. Janus kinase (JAK) inhibitors are gaining prominence in the treatment of both psoriasis and psoriatic arthritis (SA). These two conditions often coexist and share a common inflammatory basis, making JAK inhibitors a useful option for managing both skin and joint symptoms. Below is a detailed overview of their use in these conditions. Psoriasis and psoriatic arthritis. Overview. Psoriasis, a chronic autoimmune skin condition characterized by scaly, red, and inflamed plaques. The most common form is plaque psoriasis. Psoriatic arthritis, SA, an inflammatory arthritis associated with psoriasis, affecting joints and entheses, the sites where tendons or ligaments insert into the bone, leading to pain, swelling, and potential joint damage. It can present in various patterns, including peripheral arthritis, axial involvement, and enthesitis. JAK inhibitors in psoriasis. 1. Approved JAK inhibitors for psoriasis. Deucravacitinib, SOC2, a selective TYK2, tyrosine kinase 2 inhibitor, which is part of the JAK family, was recently approved for moderate to severe plaque psoriasis. Deucravacitinib specifically targets the TYK2 pathway, which plays a crucial role in the pathogenesis of psoriasis by regulating cytokines like IL-23, IL-12, and type 1 interferons. Tofacitinib, Xeljanz. While primarily approved for rheumatoid arthritis and PsA, tofacitinib has also shown efficacy in treating psoriasis and is used off-label in some cases, particularly for patients with moderate to severe disease who are not responsive to other treatments. 2. Efficacy in psoriasis. Deucravacitinib. Clinical trials have shown that deucravacitinib significantly reduces psoriasis severity, with many patients achieving PASI 75, 75% improvement in the psoriasis area and severity index, and PASI 90 scores, indicating a high degree of skin clearance. Its selective targeting of TYK2 provides a novel mechanism that may result in fewer systemic side effects compared to broader JAK inhibitors. Tofacitinib. Tofacitinib has been shown to reduce the severity of plaque psoriasis and improve patient-reported outcomes, though its use is more limited due to safety concerns with long-term use. 3. When are JAK inhibitors used in psoriasis? JAK inhibitors are considered for moderate to severe plaque psoriasis, particularly in patients who have not responded to or are intolerant of conventional therapies like methotrexate, cyclosporin, or biologics, e.g., TNF inhibitors, IL-17 inhibitors, IL-23 inhibitors. Deucravacitinib is especially appealing for patients who prefer oral therapy over injectable biologics. 4. Safety profile in psoriasis. Infection risk. Similar to other indications, there is an increased risk of infections with JAK inhibitors, including serious infections like TB and herpes zoster. Thromboembolic risk. Although deucravacitinib has a more selective mechanism, general concerns about thromboembolism remain with JAK inhibitors, especially in patients with cardiovascular risk factors. Lipid elevations and liver function. Routine monitoring of lipids and liver enzymes is recommended, although deucravacitinib may have a more favorable safety profile than non-selective JAK inhibitors. Malignancy risk. Long-term use may be associated with an increased risk of malignancies, though TYK2 inhibitors may carry a lower risk than broader JAK inhibitors. JAK inhibitors in psoriatic arthritis, PsA. 1. Approved JAK inhibitors for SA. Tofacitinib, approved for the treatment of active psoriatic arthritis in patients who have had an inadequate response or intolerance to conventional DMARDs. Upadacitinib, approved for PsA, it has shown efficacy in patients with both peripheral and axial involvement. Filgotinib, Jyseleca, another selective JAK1 inhibitor approved in some regions for PsA, offering a targeted approach with potentially fewer side effects compared to non-selective JAK inhibitors. 2. Efficacy in SA. Tofacitinib. Clinical trials have demonstrated that tofacitinib improves joint symptoms, reduces disease activity, and slows radiographic progression in PsA. It also helps with dactylitis, swelling of an entire digit, and enthesitis, inflammation of entheses, which are common features of PsA. Upadacitinib. Upadacitinib has shown significant improvements in joint symptoms, skin clearance, and patient-reported outcomes in PsA, with a higher percentage of patients achieving ACR 20-50-70, American College of Rheumatology response criteria. Filgotinib. Filgotinib has also been effective in reducing joint inflammation and improving quality of life in PsA, with good tolerability. 3. When are JAK inhibitors used in PsA? JAK inhibitors are typically used in PsA patients who have not responded adequately to conventional synthetic DMARDs, e.g. methotrexate, or biologics, e.g. TNF inhibitors, IL-17 inhibitors. They are particularly valuable for patients with both skin and joint involvement, as they can address both aspects of the disease. 4. Safety profile in SA. Infection risk. As with other conditions, JAK inhibitors increase the risk of infections, including serious infections. Vaccination against pneumococcus, influenza, and herpes zoster is recommended before starting therapy. Thromboembolism. The risk of thromboembolism, e.g. DVT-PE, should be considered, particularly in patients with cardiovascular comorbidities. Hematologic abnormalities. Regular monitoring of blood counts is necessary due to the potential for anemia, neutropenia, and lymphopenia. Lipid elevations. Lipid levels should be monitored as JAK inhibitors can raise cholesterol levels. Liver function. Periodic liver function tests are recommended, especially in patients with pre-existing liver conditions. Conclusion. JAK inhibitors represent a valuable therapeutic option for patients with both psoriasis and psoriatic arthritis, particularly those who have not responded to conventional therapies or biologics. They offer the convenience of oral administration and have shown efficacy in reducing both skin and joint symptoms. However, their use requires careful patient selection and monitoring due to risks such as infections, thromboembolism, and malignancies. Selective inhibitors like deucravacitinib may offer a safer profile for treating psoriasis, while broader JAK inhibitors like tofacitinib and upadacitinib are effective in managing both skin and joint manifestations of PsA. JAK inhibitors have shown potential in the management of certain connective tissue diseases, CTDs, particularly systemic lupus erythematosus, SLE, and to a lesser extent, systemic sclerosis, scleroderma. Their role is still being explored through clinical trials and off-label use. But emerging data suggests that JAK inhibitors may offer benefits in these complex autoimmune conditions. Role of JAK inhibitors in systemic lupus erythematosus, SLE. 1. Mechanism of action in SLE. SLE is driven by a complex interplay of immune dysregulation, including the overproduction of autoantibodies and cytokines such as interferon alpha, IFN-A, IL-6, and IL-12/23. JAK inhibitors, by targeting the JAK-STAT pathway, can modulate the signaling of these cytokines. This broad immunomodulatory effect could help reduce the chronic inflammation, autoantibody production, and organ damage seen in lupus. 2. JAK inhibitors studied in SLE. Baricitinib, Olumiant. Baricitinib is the most studied JAK inhibitor in lupus. It has shown promise in clinical trials, particularly for treating lupus arthritis and cutaneous lupus. In one phase 2 study, baricitinib demonstrated improvements in lupus symptoms and disease activity scores, e.g. SLE. Tofacitinib, Xeljanz. There are limited data on tofacitinib in lupus, but case reports and small studies have suggested potential benefits, particularly for lupus nephritis and refractory cutaneous lupus. It has been used off-label in some cases. Other JAK inhibitors, newer JAK inhibitors such as upadacitinib and filgotinib, are under investigation in SLE, but data are currently limited. 3. Efficacy in SLE. Lupus arthritis. JAK inhibitors like baricitinib have shown efficacy in reducing joint pain and swelling in lupus patients, similar to their effects in rheumatoid arthritis. Cutaneous lupus. Improvements in skin symptoms have been observed with JAK inhibitors, likely due to their effect on interferon signaling. Lupus nephritis. Early data suggest that JAK inhibitors may have a role in treating lupus nephritis, especially in patients who are refractory to conventional immunosuppressive therapies, but more studies are needed. 4. Safety in SLE. Infection risk. As with other autoimmune diseases, patients with lupus treated with JAK inhibitors may be at increased risk for infections, including serious infections like TB and herpes zoster. Thromboembolic risk. Given the increased baseline risk of thromboembolism in lupus patients, the risk of DVT and pulmonary embolism with JAK inhibitors is a concern, and careful patient selection is critical. Other considerations. Monitoring for hematologic abnormalities, liver function, and lipid changes is necessary, especially in patients with lupus, who often have complex comorbidities. Role of JAK inhibitors in systemic sclerosis, scleroderma. 1. Mechanism of action in systemic sclerosis. Systemic sclerosis is characterized by fibrosis, vascular damage, and immune dysregulation. JAK-STAT signaling plays a role in the inflammation and fibrosis seen in scleroderma, suggesting a potential role for JAK inhibitors in modulating these processes. However, fibrosis is less directly driven by cytokine signaling than inflammation, so the efficacy of JAK inhibitors in treating scleroderma may be more limited compared to inflammatory diseases like RA or SLE. 2. JAK inhibitors studied in systemic sclerosis. Tofacitinib. There are limited case reports and small studies suggesting that tofacitinib may help reduce skin thickening and joint symptoms in scleroderma. However, larger clinical trials are needed to confirm these effects. Baricitinib. Olumiant. Baricitinib has shown potential in preclinical models of fibrosis, and early clinical data are being gathered, but there is not yet strong evidence to support its use in systemic sclerosis. 3. Efficacy in systemic sclerosis. Skin and joint symptoms. Some improvement in skin fibrosis and joint inflammation has been observed in a few case reports, but these findings are preliminary. Pulmonary involvement. Systemic sclerosis often involves interstitial lung disease, ILD, and while there is interest in the role of JAK inhibitors for ILD, data remains scarce. Antifibrotic drugs like nintedanib are currently the mainstay of treatment for scleroderma-related ILD. 4. Safety in systemic sclerosis. Infection risk. Patients with systemic sclerosis are at risk for infections, particularly due to gastrointestinal involvement and malabsorption, so the use of JAK inhibitors requires careful monitoring. Cardiovascular and renal considerations. Systemic sclerosis often involves cardiovascular and renal complications, so the risk of thromboembolism and other side effects from JAK inhibitors must be carefully weighed. Conclusion. JAK inhibitors show promise in the management of systemic lupus erythematosus, particularly for lupus arthritis and cutaneous lupus. Baricitinib is the most advanced in clinical trials, while tofacitinib and other JAK inhibitors are used off-label with some success. However, safety concerns such as infection and thromboembolism require careful patient selection and monitoring. In systemic sclerosis, the role of JAK inhibitors is less clear. While some early data suggest potential benefits for skin and joint involvement, more robust clinical trials are needed. The primary focus in systemic sclerosis remains on antifibrotic therapies, with JAK inhibitors being a potential adjunctive treatment rather than a primary option. Overall, while JAK inhibitors may become important tools in the management of certain connective tissue diseases, further research is needed to fully establish their role and safety in these complex conditions. The use of Janus kinase JAK inhibitors in pediatric patients is a developing area of research and clinical practice. While JAK inhibitors have shown promise in treating various autoimmune and inflammatory conditions, their use in children requires special considerations regarding safety, efficacy, dosing, and age restrictions. Approved JAK inhibitors and minimum age for pediatric use. 1. Tofacitinib, Xeljanz. Minimum age. Tofacitinib is approved for use in children aged 2 years and older with polyarticular juvenilopathic arthritis, JIA. Indications. Tofacitinib is used for polyarticular JIA in patients who have had an inadequate response to one or more TNF inhibitors. Dosing. Pediatric dosing is based on weight. The typical dose for children is patients 40 kilograms, 5 milligrams twice daily. Patients 40 kilograms, 3 milligrams twice daily. Considerations: dose adjustments may be needed in cases of renal or hepatic impairment. For children on strong CYP3A4 inhibitors, e.g., ketoconazole, the dose may need to be reduced. 2. Baricitinib, Olumiant. Minimum age. Currently, baricitinib is not broadly approved for pediatric use, though studies are ongoing. However, it is being investigated in juvenile idiopathic arthritis, JIA, and other pediatric inflammatory conditions. Indications: off-label use may occur in specialized settings, but this requires careful consideration of risks versus benefits. 3. Upadacitinib, Rinvoq. Minimum age. Upadacitinib is approved for use in adolescents aged 12 years and older for the treatment of moderate to severe atopic dermatitis. Indications: in addition to atopic dermatitis, upadacitinib is being investigated for other pediatric autoimmune conditions, including juvenile idiopathic arthritis and Crohn's disease. Dosing: the typical dose for adolescents with atopic dermatitis is 15 milligrams once daily. Pediatric indications for JAK inhibitors. 1. Juvenile idiopathic arthritis, JIA. Tofacitinib is the primary JAK inhibitor approved for treating polyarticular JIA in children 2 years and older. Baricitinib and upadacitinib are being studied for JIA and may offer future therapeutic options. 2. Atopic dermatitis. Upadacitinib is approved for treating moderate to severe atopic dermatitis in adolescents aged 12 years and older. JAK inhibitors provide a new option for patients who have not responded adequately to topical therapies or systemic immunosuppressants. 3. Other potential indications: inflammatory bowel disease, IBD. JAK inhibitors like tofacitinib are being explored for pediatric IBD, Crohn's disease, and ulcerative colitis, though this remains an off-label use at present. Systemic lupus erythematosus, SLE, and vasculitis. Ongoing research is examining the use of JAK inhibitors in pediatric lupus and vasculitis, but these are not yet standard treatments. Pediatric dosing and adjustments, weight-based dosing. Pediatric doses of JAK inhibitors are often calculated based on weight, with specific dose adjustments required for children under a certain weight threshold, e.g., 40 kilograms for tofacitinib. Renal and hepatic impairment. Pediatric patients with renal or hepatic impairment may require dose reductions or more frequent monitoring. Co-administration with other medications. When used alongside strong CYP3A4 inhibitors, e.g., antifungals, certain antivirals, the JAK inhibitor dose may need to be adjusted to avoid increased drug levels and toxicity. Safety precautions in pediatric use. 1. Infection risk. Pediatric patients on JAK inhibitors are at an increased risk of infections, including upper respiratory tract infections, pneumonia, and herpes zoster. Vaccination history should be reviewed, and patients should be screened for tuberculosis, TB, before initiating therapy. Live vaccines should generally be avoided during treatment with JAK inhibitors. 2. Growth and development. The impact of long-term JAK inhibitor use on growth and development in children is not fully understood. Regular monitoring of growth parameters is recommended, and caution should be exercised with long-term use. 3. Thromboembolic events. Although the risk of thromboembolism, e.g., deep vein thrombosis, pulmonary embolism, is a concern in adults, its incidence in pediatric populations is less clear. However, JAK inhibitors should be used cautiously in children with known risk factors for thrombosis. 4. Malignancy and immunosuppression. The long-term risk of malignancies, including lymphoma and skin cancer, is a consideration with JAK inhibitors, especially in children who may be on these therapies for extended periods. Routine skin checks and malignancy screening are recommended. 5. Hematologic monitoring. Regular monitoring of complete blood counts, CBC, is necessary, as JAK inhibitors can cause cytopenias, e.g., neutropenia, lymphopenia, anemia. Sick lipid and liver function. Periodic monitoring of lipid profiles and liver enzymes is recommended, as JAK inhibitors can cause increases in cholesterol levels and liver enzymes, even in pediatric populations. Conclusion: JAK inhibitors are increasingly being used in pediatric patients, particularly for juvenile idiopathic arthritis and atopic dermatitis. Tofacitinib is approved for polyarticular JIA in children aged 2 years and older, while upadacitinib is approved for atopic dermatitis in adolescents aged 12 and older. These drugs offer new therapeutic options for children who do not respond to conventional treatments, but careful consideration of dosing, safety, and monitoring is crucial. Further research will clarify their role in other pediatric autoimmune conditions and help establish guidelines for long term use.